were low. And of course, biases towards the null hypothesis. If all the CTOs had been revascularized, would the result of the ischemia trial been different? I'm asking the question, and it was mitigated with complex modeling. We got some new data as well this year that was presented at CTO Plus. The STAR technique is a bailout technique where we reopen the vessel with the STAR technique at the end of the procedure. So they looked at, when we're doing this, when failing, is it better to bring the patient around 6 weeks or around 12 weeks? And they look at quality of life. So what they found is that when they're doing the second procedure, the reattempt at opening the CTO, they were more successful when they would do it earlier than when they would bring the patient at 12 weeks. So basically, if you're doing a STAR, you're better off to bring the patient around 6 weeks than bring the patient 3 months, because your likelihood to be successful, there was a strong trend in favor here. However, when you look a bit more at the data, it is not as nice as it shows, because when you look at the complete revascularization, which is complete success, meaning all the branch being open, it was only 67 versus 61. So basically, when you reattempt a patient after a STAR, your success rate is not very good. It's like 65, 67%. So it raises the question of, we're awaiting the publication. It's better to bring the patient earlier than later. It's unknown if the STAR is safe, because they recruited the patient after the STAR. So all the ones that had perforation and everything, they were not into that registry. So STAR was safe in that study because they were all recruited after the STAR. And it raises the question about STAR. Is it a STAR strategy? Is that really good? Because in the end, if you bring the patient back later after starring and you're just successful in 2/3 of the cases, it raises the question. So that's the reason why I think the global chronic total occlusion algorithm still maintains the STAR technique as a bailout strategy when others have failed. So in conclusion, CTO PCI is a mature procedure, so it's well covered in that paper, and I invite you to read it. It's beautifully put together by Manos. There's strong additional data on the adverse effect of coronary CTOs on mortality. That SCAR registry is quite impressive. The ischemia trial revascularization success of CTO vessel was low compared to contemporary CTO PCI registries, and you could ask yourself if we'd been better at revascularizing the CTOs in that study had it been different as an outcome. Despite this, the invasive management and revascularization of patients with ischemia who have CTOs in that study was associated with lower MIs and improved quality of life. And maybe revascularization of the CTOs may further reduce the ART events. And I showed you with the STAR study that bringing the patient earlier might be better than waiting 3 months, but the overall success rate afterward are relatively low. So thank you very much for your attention, and we'll look forward to look at all the cases today.
Thanks, Stephane. Also for the audience, if you have any questions, please raise your hand, and then there's a microphone in the front. I have a microphone here, so if you raise your hand, it will be to you.
Thank you for that excellent review. I'm just going to start down at this end of the panel. So I think looking at that data collectively, like all stable ischemic heart disease, I think we can agree that the main indication to take patients for coronary intervention is symptoms. However, are there situations still in the CTO subset where any of you are going on the basis of other indications to improve LV systolic dysfunction or high burden of ischemia on non-invasive testing, or have you moved away from those kinds of indications?
Thank you, Alison. A great question. For us, it's predominantly ischemic symptom management. For sure, most of the patients who undergo CTO PCI are for symptom management. And of course, the patients who have ischemic cardiomyopathy, low ejection fraction, after a heart team discussion, we do consider a revascularization in those patients. Of course, we have to keep in mind the inclusion-exclusion criteria of the REVIVE BCS trial too. I mean, if there's patients coming in with acute decompensated heart failure, those patients were excluded from the REVIVE BCS trial. So in those patients, I do consider CTO PCI, especially in the setting of multivessel disease. Predominantly outpatients who are doing well, no symptoms, then not much for LV dysfunction.
mean, I think that's pretty much what it comes down to. Symptoms are really what are driving this. So patients with ischemic cardiomyopathy are symptomatic. I think it's easy to justify. In patients who are incidentally discovered to have ischemic cardiomyopathy, it's sort of a hard lift to suggest that the risk of the procedure is worth it.
I tend to agree with what everybody else said. It's primarily symptoms. There are cases where patients have large areas of ischemia with LV dysfunction where we will consider it, but it's mostly for symptoms.
Perfect. I think maybe just for this half of the panel, anyone want to comment on how, if at all, they've incorporated STAR into their practice and where they've found it to be helpful?
Yeah, like Stephane mentioned, primarily as a bailout. I don't think we go with upfront start strategy, but mostly bailout. And like Stephane mentioned, I'm also not entirely sure the overall benefit of bringing a patient 6 weeks versus 12 weeks, because if you look at the complete technical success with preserving all the branches, the difference is not significant. So I think the answer is probably still unknown when to bring them back, but we primarily use as a bailout strategy.
I bring the patients in 10 weeks currently after a STAR procedure. I was actually wondering what the rest of the panel, what's their practice?
Yeah, for us, I think I agree with everybody else. It's as a last option if you don't have anything else. Like if it's a small or an OM CTO that you don't have a good retrograde option, possibly instead of going through an epicardial, maybe you can just start and see what happens in 6 to 8 weeks. I've heard the other question is I've heard a lot of people use like they would STAR. Obviously, you don't want to stent, but they have DCB and had good results. Even when they come back, they didn't have to do anything. The vessel looked good. So I don't know. I've done it once, and I had good long-term results, but I don't know what the panel has.
I've used the DCB in a limited number of cases, and I've had mixed results, sometimes excellent results. Other times it's re-narrowed significantly by the time of the relook, and I've had to do other things, but I'm not sure about other individuals.
I've just added one layer to my practice. So investment, STAR, whatever you want to call it, what I do at the end is I've already dissected and dilated this plane. I put IVUS in and examine the plane to see if I can find the lumen again, and then use that to do an IVUS-guided re-entry. So I always finish off the case with that, and honestly, I found that to be remarkably effective. So that's sort of like an additional layer that I add on top since I've already dilated the vessel.
Yeah, that's a good point. I think there's a pressure there. There are some people advocate the use of STAR to sort of reduce the overall risk of some procedures that might be. So maybe doing STAR might be a better approach than using a very higher risk epicardial collateral in some situations. And I agree in some cases that it might be reasonable as an option. However, I think we cannot, at this point, look at the data and say that the longer-term patency of such a strategy is satisfactory at this point. We're taking a step back to what is expected with all the current techniques that are not, dissection and reentry with wires.
Yeah, I think certainly getting the further data in this sphere is going to be helpful to guide us further. I think in the interest of time, we'll move on to our first case speaker. So a vascular path, Dr. Ahmed Al-Ogaili, welcome to the stage.
And also for the people at the back, there are small seats over there. If you guys want to sit, there are seats on the other side of the room, so feel free.
All right, thank you so much for the opportunity. So it's a slightly long case, so I'll, oops. All right, no relevant disclosure. So the patient was a 57-year-old woman who basically presented with claudication. She also had significant dyspnea and activity. She was recently admitted to an outside hospital with NSTEMI. They cathed her and found complex CAD. She had a history of hypertension, and she was a former smoker. Her echo showed normal EF, no significant valvular pathology, and her ABIs were remarkably positive on both sides. So this was the angiogram from the outside hospital. Basically, you see a mid-RCA CTO at the takeoff of a big marginal branch, which through epicardial collateral supplies an LAD that seems to be occluded as well. The circumflex had mild to moderate disease, nothing critical. And then on the cranial projection, you can see basically an occluded mid-LAD with a lot of branches and ambiguous cap, but probably at a takeoff of a proximal septal branch. So the patient was sent basically for CABG evaluation, and the surgeon obtained a CT of her aorta, basically planning for surgery. And the CT basically showed this. So the distal aorta was occluded, and interestingly, both mammary arteries from both sides collateralize her femoral arteries, as shown in the panel on the right. So because of that, basically, and because he can't use these mammary arteries, he turned her down for surgery, and they sent her for us to consider a percutaneous revasc. So again, I mean, the problem with her, I guess, access is limited. She's a very small lady. She's 5'1", 100 pounds, really small, like radial arteries. I guess the other question is, what is the sequence of revasc? Would you start with the LAD or the RCA? Would you try to do everything in one session, given the multiple access options? Would you try to divide it into two procedures? So we took her to the lab. I was able somehow to get 2 7 French, one from the ulnar on the right side and one from the radial on the left. Unfortunately, she was having a lot of pain and spasm, and I had to manipulate the AL guide multiple times. As you can see with the dual angiography, unfortunately, we dissected the right coronary artery with the first picture. So at this point, I tried to, with soft wires, to get back into the true lumen, but I checked with IVIS. I was subintimal. So decided to try the retrograde. There was the first septal, basically had possible connection, wasn't that promising with a tip injection, but we did surf it with a SUO3 wire and a Caravel microcatheter. And surprisingly, actually, the wire went quickly into the distal RCA. So after that, we followed with the microcatheter. And we did a tip injection. I thought I was coming through the PDA, actually, in this picture. And then it's just a small RCA. So I used the Mongo, and I was able to successfully wire the antegrade guide. And we externalized with an R350 wire, and then we ballooned and stented all the way to the ostium from the distal right. And we achieved an okay result. Before finishing the case, I did a dual injection with a microcatheter and the LAD just to understand the LAD CTO better and plan the next procedure. And again, you can see a blunt cap at the takeoff of that first septal calcified occlusion, and the distal cap is at the takeoff of that second septal branch with a diffusely diseased distal vessel. Brought her back. This time, actually, I did the case with anesthesia just to help get equipment in, but I couldn't even get a 6 French catheter this time, even with balloon-assisted tracking. So I ended up actually sticking both brachials on both sides, and I put 6 French in one and a 7 French in the other. This time, actually, I was pleasantly surprised. So what I thought was the PDA was actually the PL, and now you can see actually the PDA, which was not filling at the end of the first case. It was jailed by my stent, so I actually stented into the PL, not knowing that there is a PDA. So I tried to get an IVIS into that first septal branch to do IVIS-guided puncture of the proximal LAD, but despite dilating, there was calcium there. I couldn't get the IVIS in. So I basically used the Gaia, just tried to aim for resistance, poke the proximal cap, but the wire was subintimal. So I used a second wire, a Gaia third, tried parallel wiring briefly, but the vessel was diffusely diseased. I wasn't able to find the true lumen. So I got back into that PDA, which was filling now. Again, there was possible septal connection. Surfed them again with the same combo, Caravel and SUO3. And with a little bit of manipulation, this was a little bit more tortuous, the the septal going into the LAD. But with some manipulation, we were able to get into the LAD, as you can see here. Yeah, so then we confirmed and then followed with a microcatheter and then punctured the distal cap with a Gaia second. The wires were like, there was a big separation between the wires, so I pulled actually the anti-grade wire, and I came back with a Mongo and just knuckled the Mongo, which went a little bit closer to the Gaia, and I was, as you can see here, basically it was much closer this time. Did guide extension reverse cart and basically used a dual lumen microcatheter to secure the distal LAD. And then had, unfortunately, to put long stents because the whole vessel was diffusely diseased. And this was the final angiogram. So this was our basically before and after both arteries. The patient did well, actually. She went home like the next day after both procedure. I guess some teaching point from this case is that, like, despite limited access, despite complex disease, I think we always want to do 8 French femoral, but you can do a lot of these cases with smaller guides through upper extremity access, ulnars, radials, or brachials. I think retrograde is an option to treat guide-induced dissection, whether in a CTO or a non-CTO intervention. I think the other point is that in cases with multiple CTO, maybe try to start with the one that can facilitate opening the second one. So in our case, we started with the RCA. We had septals collateral form from the PDA, and then we were able to open the LAD with retrograde through that PDA. And that's all I have. Thank you.
Thank you so much. That's a fabulous case presentation. A lot of really important decision points and learning points there. So you commented about the access. I think it's an important reminder to think about your alternative upper extremity access, your ulnar and your brachial in cases like this. Just to maybe get some comments from the panel, I know myself, I've been in that situation where I get set up for a CTO, and unfortunately, I have had a guide-induced dissection. Often it is the RCA. Maybe we can just talk about some of the options to address that. You talked about retrograde, which is one great option. Any other comments from the panel about that?
You used IVUS to try to get back in, correct?
Yeah, I tried, but again, I didn't change the guide, so the guide was a little bit deep. Maybe if I would have changed to a JR, for example, I would have had better luck. But with the same guide, because I didn't want to pull the guide out with the spasm she was having, yeah, I couldn't. I checked with IVUS, yes.
I would say IVUS would be my first choice. Parallel wire might be a second choice if you can disengage your guide enough to be able to get a second wire in there and perhaps try to find the true lumen that way. I guess I had another question. How much contrast did you use for the first case, and did you think about going after the second CTO during the first case, knowing that she's a vasculopath and you might have issues getting back in?
Yeah, I don't remember exactly, but it wasn't a lot of contrast. But the problem is she was like very uncomfortable on the table. She was moving a lot. She had a lot of pain in her legs and her arms. So I don't think I could have done the second case during the same session. Actually, I have a question. I don't know. I was trained by, where's that? Not to use side holes. So I don't know if you guys use side holes for your RCA, and I don't know if your experience is that less guide-induced dissection of side holes.
I think that's a big matter of debate amongst operators. So you can potentially raise pros and cons to each approach. I think having the side holes there, you have more comfort that you're not going to get significant dampening and experience a dissection like that. But some people feel that they get more immediate feedback about dampening if they don't have the side holes, so they manage their catheter differently in response to that. I think you just need to know what you're doing and pay attention to your feedback, whichever approach you're going to take there. Some people have very strong opinions. I'm
I don't know about the side hole thing, but for right coronaries that I'm doing radially, I like to use a 3D right guide, because that lets me be deeply intubated or more passively intubated just by torquing the catheter back and forth. So it gives me a little bit more control. So I prefer that guide catheter for radial rights. I just think that, in my hands at least, it seems to give me a little bit more flexibility. I don't know if anybody else has any thoughts.
Yeah, I don't feel strong about. I don't feel strong about the antegrade, but for the retrograde, for the donor guide, I really, if they get me a guy with side holes, I will not work with it. So for me, it's the pressure curve that is the most important for me. Whenever it damps, whatever, it's that, because the donor artery dissection is very scary complication, and I think it depends on how much time you have. If the patient tolerates and you can do this, you can do fancy work and IVUS and parallel wire, but sometimes you don't. I remember a case that I had like 3 years ago. It was through a TAVR, so she had like a TAVR, a core valve, and that was not very coaxial in that, right? And she had a circ of an she had the circ CTO, LED CTO, and the donor was going to 2 arteries. And I dissected the right. So I got to tell you that this is the fastest star I've ever done. And she didn't, her pressure didn't budge because I reopened very, very quickly the vessel. But I think you got to be very comfortable with star, and it all depends on the situation. This is a technique that can save the patient, literally. So I think it's also, it's a technique that, I said a lot of negative on it just earlier, but it's a technique that on a short term can make a huge difference for the patient.
Yeah, that was one of the reasons I brought that up. That's a great way to bail yourself out, is to do a star in that scenario. And another thing I've done as well, if the patient is a little bit more stable, is I've just used it as a platform to do ADR with a stingray as well. I think in your case, you didn't have as great distal visualization of the vessel initially, so it's harder to trust that. But if you do, it's a great option. Okay, thank you so much for your case. I think we'll move on to our next speaker. Audience question? Yes, go ahead.
So incredible case. Just 2 actually non-CTO questions. 1, what did you do with the brachial access at the end? And 2, did you consider just sending her to have the distal aorta opened and then sending her for cabbage?
Yeah, so actually she met with our peripheral, the second question, peripheral people and vascular surgery people, and nobody would touch her without opening the coronary. So that the sequence, she actually went for surgery after revasc. That's number 1. Number 2, I did manual pressure. She was so thin, I was worried about putting any closure device. She had no subacute tissue, so we just did manual pressure for the brachials.
Okay, I think we'll welcome Dr. Anthony Spaedy, retrograde lessons, please.
Okay, thank you. Yeah, I was going to say those were great cases, and I'm still amazed how much I'm still learning after doing this for a while. So for me, it's not. I think it's become almost routine. You do these complex cases, and there's just some surprise every time. So I'm going to show a case that was referred from an outside hospital. This is a 60-year-old diabetic with chronic kidney disease. His creatinine's about 2. And he's been having, he didn't tell his wife or anybody, he's been having angina for a couple of years. He just kind of just didn't want to mention it to anyone. And then he presented acutely to an outlying hospital with a non-STEMI recurrent chest discomforts. And they took him urgently to the cath lab. He had some congestive heart failure as well. And initially they thought, they couldn't tell, the EKG was a little ambiguous, exactly what had caused his significant bump in troponin, and they were worried it was the circumflex. And when he presented, his right coronary artery was occluded, his circumflex marginal was occluded, and his proximal LAD was occluded. So they worked on the proximal circumflex, couldn't get any wire to go through the occlusion, and subsequently probed the LAD, and it went through pretty easily. But once they opened the LAD, I'm not going to show all those pictures, but once they got some flow down the LAD, they put a couple stents in. It still looked terrible distal to their stents, so they put another stent, I think he ended up getting 4 stents to his LED. So you can tell there that LED is a full metal jacket, and it's still very tiny at the end. He's a diabetic as well. So the hope was this would plump up by the time he came to us. He did still continue to have symptoms afterwards. His ejection fraction was 20%. He was seen by the heart failure team. He had an MRI that showed a substantial amount of viability in the circumflex and right coronary systems. He was seen by surgery, and eventually he worked his way to be considered for CTO intervention. So you see when he comes back, his LED is open with a bunch of extensive stenting. The distal vessel looks pretty poor. You can see the distal right coronary here on the collaterals. A lot of this was suspicious by the films that it might be epicardial, but we were hoping there might be some septal connection. You can see a big septal there that has potential. Here's what his circumflex looked like. This is kind of ideal, I think, for intervention. It's tapered, probably not terribly long. We don't see a lot of calcium. So we actually, I'll show you the right in a second, but we did the circumflex first, which went fairly well, and we didn't use much dye. So we just used kind of a Mongo with the support catheter, went through pretty quickly, and we IVUSed and stented the circumflex. So you'll just see afterwards. Take out a lot of pictures here. You can see the right filling distally. So we're trying to keep our dye limited. So I actually put in a small guideliner just because I was wanting to see, without giving much dye, if I could just get some really good pictures of that septal. Sometimes that's an option. You can see there's something that looks pretty tempting as an option. We did go ahead then kind of start with an antegrade approach on the right coronary artery. And most of this went pretty standard. We had a low threshold to try retrograde because we thought we might have a usable septal, and it was a blunt cap on the right coronary artery. So our thought was we would try antegrade, but if we have much trouble getting subintimal, we can either use Stingray or go down the septals. I will say we checked his EDP first. He was well compensated time. He was able to lay flat. His EDP was 10 or 12. And so we did not do any kind of support, right or wrong. And then here's his right coronary artery. You can see severe disease proximally, kind of an ulcerated lesion at the end of our AL 0.75 guide. This is another one you might worry about dissecting with the Amplats. We put it in pretty carefully, I guess. Sometimes I'll start with the JR4 or JR5 or an ART or something as well. But this one, it looked like it was working fairly well. So we did go ahead and leave that in there and tried antegrade initially with the jacketed wire. We tried a Mongo and then a Gladius, but we had trouble getting subintimal. So I'll just show you. We decided to come down through stent struts. You can see our subintimal wire in the right coronary artery, or it's kind of a little curved over, but we weren't making any progress. And so we bring down our microcatheter. We feel a little resistance where the stent struts are, so we dilate it with a 1.5 balloon just to maybe lower our chance of getting something stuck or wedged in there a little bit. And then we were able to wire it fairly straightforward with a Cihan black into the distal right coronary artery. We took a picture, and it looked like it was going the right direction. Although in retrospect, something caught my eye, it might catch yours. At the time, then we brought our microcatheter through and switched out for a Mongo to go retrograde. And the Mongo actually moved up really smooth. You know, a lot of times there's a retrograde microchannel by autopsy series. So I thought maybe we just went in a retrograde microchannel. We go up to the other wire. It meets at knuckles. You can see there it seemed like it was forming a knuckle pretty naturally. We had no resistance. So we did go ahead and push that knuckle up more proximally. And we actually ballooned then that proximal lesion just to help us maybe get a little higher subintimal and a little more comfortable zone to knuckle proximally. So here we bring down, this wire movement might look a little schizophrenic, but actually we were doing it pretty gently. It was going out branches. And eventually we pull back and it forms a good knuckle more proximally, right about here. It forms a more natural, healthy looking. We feel resistance. Bring down our microcatheter to give a little more support. Right there. And then push the knuckle a little harder. And it moves forward in a way that felt in that it was the way it was supposed to be. The knuckle behaved in a way we liked. So it was actually a pretty straightforward reverse cart then. We did a guideline or facilitated reverse cart and ballooned the right coronary artery. I want to show you the next picture. There was something that I kept having in the back of my mind from a previous picture. So we did a retrograde shot here before we IVUSed. And I don't know if you can see very well, but you probably can. In the distal right coronary artery, there's a double shadow. Kind of almost looks like you've got a microcatheter down there or something. It just looks not what I expected. So somehow early we had caught something and gone subintimal, even though the wire, it's another example of how these jacketed wires sometimes in a non-calcified vessel can move pretty easily. But you'll see on the IVUS, I think this is great if you haven't seen this much, to see that subintimal. So we're in the false lumen on our ultrasound. This is mostly looping, but you can see the true lumen, the little fish mouth opening and closing, and then the part that has the IVUS catheter looks really clean, like there's no media, there's no plaque or anything. So it's kind of a classic appearance of and this is distally. So we're subintimal, kind of from the distal all the way back to where we knuckled proximally. So this is not a typical STAR case, but it's kind of similar to a STAR case. And in this one, we didn't want to give this guy very much dye, and we'd already done a fair amount. So we elected to just balloon it all and take a tiny injection at the end. This is just a couple cc's, very gentle. And you can see we've got flow down there. And that our plan was just to let him go home and come back in 7 or 8 weeks. And that's what we did. So I want to show a couple things. One, the surprise when we get back. Maybe it's not a surprise. You'll see this every once in a while with a STAR. I wasn't expecting it with this one. But we bring him back and probably just needed to put in one guide. And so you see there's no collaterals going to the right coronary at all 2 months later, and also his symptoms were better when he came back. So sometimes after STAR, you bring them back and their symptoms are doing quite a bit better. And that's the ones I think you kind of have to be suspicious. Maybe it's still open. So his circumflex looked the same, no collaterals to the right. And then we take this picture of his right coronary, and it's got good flow. There's a lot of disease in the posterior descending branch. I'm not sure exactly where we came in, but there is a little small branch between the PDA and the PLB. We probably came in somewhere there retrograde and grabbed a little plaque and got subintimal. You can see in another view that, of course, because of all of our subintimal work, it looks a little rough in the mid-segment, but there's a lot of disease distally. So we did just go ahead. You see some collaterals kind of now going over to a septal that was stented over from his original intervention. But then we did go ahead and IVUS stent optimize the right coronary artery and just show you the end here. So it actually, what we had scheduled for a little more time in the lab turned out to be kind of a quick case, which is always a gift, especially how some of these can go. So anyway, for me, it was just an interesting case of we got in the wrong plane, got subintimal, definitely caused the dissection, but it didn't ruin everything actually when we came back. This is a case where the STAR did kind of make it much more simple the second time around.
That was a great case. Thank you so much. You ended up, I think all experience, like retrograde operators using septos, we've all used what I call the right ramus. It's not rare that you will connect in something that is between the PDA and the PL right at the carina. And I called it the right ramus. And this is exactly what you ended up doing. And then probably you got a plaque and you dissected it. It's a great example of, even if you connect and your wire is going into the vicinity, those subtle, signs are important to sort of pick up. Although it's probably okay that you didn't realize it, because had you realized it, you would have probably not had the longer-term success. So what's your thought on this?
Yeah, I think that's right. So sometimes when everything goes great on a reverse cart, you don't even do another retrograde injection, or I don't. You know, you IVUS and then go ahead. But what if you skip IVUS, like you showed, 60% get IVUS and something like 40% of CTOs don't get IVUS? Is that what was the data earlier? I mean, that IVUS was extremely revealing, and it's also just a good example. So I thought that made it very clear, even though we had some flow. I think if we would have skipped the one picture and skipped the IVUS and just stented, then we probably would have ruined that vessel. Even if you had a little flow at the end, it would have closed eventually.
I thought it was a great case. I think that, I mean, I'm going to sound like a broken record, but this is one where I would probably put an IVUS, left the IVUS there, brought a second system down, and parallel wired with the IVUS in real time to tell me where the false is, and then just rewired the true, because it was right there, just staring at you. Yeah. No, I think your points, yeah, when you talked about that earlier, I thought, maybe I'll try that next time, but I haven't done that.
Tony, that was a great case. I think a lot of us want to know, when you ballooned that artery, that right, how big of a balloon did you use, and why did you go down that road or that approach?
We just used a long 2.5 balloon, nothing too aggressive till we IVUSed, and kind of my plan was still at that time that we're probably okay until we took the other picture and showed, hey, there is an issue. But so really I was doing it just kind of like a standard reverse cart, preparing for stenting.
I just have a question about the ballooning as well, just out of interest. Did you balloon all the way down to the point where your retrograde wire entered, or did you just balloon more like an investment higher up?
Yeah, we ballooned where on the retrograde, there's a retrograde picture where it looks like there's a distal length. You know, if you did do a stingray, there was about 2.5 or so 3 centimeters of distal right before the bifurcation. So I kind of ballooned up to where it looked like it pinched on the retrograde shots so that we'd cover that all the way back. All right, thank you.
That was great. So our next presenter is Arasi Maran, and she selected a case named When the CTO Fights Back. So I guess you have to fight hard, right?
Yes, I think the right coronary artery is the theme of this session, but so I'll follow suit with that. Well, thank you so much for the opportunity. This is a case I struggled really hard, and it just felt like it's fighting back and doesn't want to be opened. So this is a 64-year-old white male with worsening angina. Nuclear stress test revealed severe anterior anterolateral ischemia. EF was 55. This was earlier, in 2019. Then he had his entire cabbage was done. And after that, he continued to have angina. And at that time, his left main was a stump. RCA was osteal CTO. Vein graft, the other vein grafts was open. A lima to LAD lesion was noted, and the operator at that time went through the lima and fixed the LAD at the anastomosis and kind of jailed the rest of the lima. This is important, and you will see why. He got better, etc., but then progressively had worsening angina, and now comes to me. I get a cardiac MRI, usually in these patients who've had bypass surgery, stress cardiac MRI, just to know what is the amount of ischemia and also the amount of infarct, is it transmural, etc. So either way, less than 25% subendocardial infarction. So therefore, there is room for you to go and treat this. It's viable myocardium, and significant ischemia was present. Maximized on medical therapy, and despite that, he continued to have symptoms. So this is a picture from my cell phone because this is what I got, and I love it when the surgeons use these sternal buttons and you cannot see any of the coronaries, and it just makes your life so much more better. Anyways, so this is the osteal CTO. You can make out the calcium to the best of your abilities. So I decided, my plan could not engage the right coronary artery to the best of my abilities, multiple guides, etc. So I had an EBU 375 in the left main, and you have to guesstimate the CTO score here, but it's a blunt cap. You can assume it's ambiguous, you can assume it's calcified, and you can assume it's long. So it's thing. Now, there are pretty much no antegrade options because I'm not even able to get a guide into the RCA. So the collaterals are coming from the lima to the LAD, backfills the LAD, and then you have some septal collaterals. But remember that somebody has stented across the anastomosis, so you have to kind of poke through the LAD stent, and I'm like, I'm not doing that through a lima to LAD. Nope, not doing that. So my plan or plans were to open in phase 1 to open the left main LAD, and then go use the native LAD septal collaterals and try to get to the retrograde. If not, try the occluded vein graft. I'm never a big fan when it's a flush occluded vein graft. This did not have that nice little beak where you can then poke. This was a flush occluded RCA vein graft. So if not, then I have to fight the antegrade war. Nevertheless, I was able to get a wire into the LAD. I used a 1.5 burr, burred it, and after the burr, okay, this was my LAD. I was like, okay, not too shabby. I can deal with this, I think. And you can see some collaterals, septal collaterals to the right. I was like, okay, this is worth the attempt. So let's see. So, but thankfully, septal surfing with Corsair and Cihan, the wire went easily retrogradely, no problem. Is there a I don't know which direction to go. But either way, so you can see the septal wire went in. So it went into the body of what you would think is the RCA. Retrograde wire escalation was done. And then from Fielder XT to Pilot 200 does a little bit of a jump. And then it goes outside of what I think is the cardiac border. And I'm like beginning to have some palpitations. I'm like, where did this wire go? And why is it jumping outside the cardiac border? Then I was like, oh, there's a vein graft. And I probably jumped into the anastomosis into the vein graft. So that's okay. Wire was redirected, got into what I thought was the body of the RCA, and kind of got all the way to the proximal RCA. And then I am trying different, this is time, it's not, I was hoping it would just fly into the aorta and I could snare it, but usually these osteal rights, you have like a shelf of calcium, almost like an awning, and the true ostium is somewhere beneath that calcium, and that's why you're not able to engage anything antegradely, because that awning is kind of preventing you from engaging. Either ways, nothing. I tried all the guides I knew. A hockey stick gave me some visualization, and retrogradely escalated up to an Astaro 20, nothing happened. So I said, okay, fine, now I have to fight the antegrade fight. Hockey stick, guide extension, Corsair, Fielder XT, went into a conus branch, could not deliver anything. I tried POBAing with the 1520, wouldn't deliver. I lost access multiple times. I'm losing patience. I'm not a patient person. So I switched to an RCB guide, got into a conus branch. So I said, okay, balloons are not going because it's kicking out. I'm losing everything. Let's do laser. I take a 0.9 laser, and this is what I get. Yes, 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 yes. Not good. The good news is I had the 1.5 Takira balloon, so I put the 1.5 balloon up, inflate it. Now I'm able to take the balloon. Everything is holding in place. Patient vitals are stable. Echo is okay. There's no effusion. I'm like, okay. And then while I'm doing all this, I go back and look at my deflator. It's back to 0. And somewhere in this, the balloon had ruptured. And despite the balloon being ruptured, the patient was hemodynamically stable. So, okay, let's give him some protamine and get the fudge out of here. But what I did, one thing was I dilated the septal collateral so that when I come back, I don't have to fight with the antegrade fight again. So competence of phase 1, could not engage the right coronary artery, difficult visualization, crazy angles. I cannot even tell you what angles. It was whatever angle. So the radiation, I mean, I had collected about 4 gray radiation, severe optimization or modification of the LAD with the ROTA, laser of the RCA, and that was it. Contained perforation. Bring him back in 6 weeks, same problems. The ostium was not good, but I could get retrograde very quickly. I was able to get to the proximal cap as well. and do IVUS-guided PCI, and then when I'm ballooning in the distal vessel, I have this undilatable distal RCA segment. I'm again tired, and I'm like, okay, fine. Let me switch from a retrograde situation to an antegrade situation, and let me rotor into the thing. And this is where I made the mistake, and I pulled all my retrograde guide out. And the moment I pulled my retrograde guide out, I lost guide access, and I could not re-engage because now I've already stented the proximal portion, and my last ballooning was that ballooning, and I could not get any more access. And at this time I decided I'm going to leave it because this is what he came with. Now he has something what he can call an RCA. It is not perfect, but there is at least a 2-vessel runoff, and I'm going to accept this and walk away from this. So cumulative radiation exposure, close to flow 4 gray for the first one, 6 weeks later 4 gray for the second one. And the radiation exposure is not because the case was long, but because it was weird extreme angles. And I mean, he's been doing well with no angina for more than 1 year. We've stopped all his anti-anginals. And so calcific CTO will fight back. Remember your algorithms. And if you have I think the biggest takeaway for me in this case, that if you have an osteal right, which you fought hard to get retrograde, finish the entire case with retrograde, because the moment you lose retrograde access and that flossing to do antegrade work is going to be extremely difficult. So with that, I will finish. Thank you.
Yeah, what a fight, huh? So it raises. I think one of the point that you're making is, I think it would have driven anybody crazy to work through these, these sternal, stuff, and we've all been there, and I see a growing number of surgeons using really very radio-opaque stuff, including left atrial occluders that are always in front of the damn left main. You can see anything, and then they come back, and you don't see you turning all around. Yes. There's no way to clear that thing. Aren't we just? Shouldn't we have a say on what they're going to be using in terms of, because they're all invariably coming back to us, and should they be made aware of, or would this industry should be maybe
we need
doing
a white
better?
Paper.
Yeah.
On best practices for the surgeons. No, but I agree with you. The younger generation surgeons are more and more using these radio opaque plates, and I had a similar AFib, left atrial appendage occluder. They're making our lives difficult, and you are right, and we have to communicate. One of my surgeons, he always places the transplanted heart a little bit more horizontally, and it was impossible to find the coronaries, to the point I got frustrated, and I called him and said, dude, I cannot. I'm not cathing your post-transplant patients because you're killing me. And he's like, what do you mean? He had no idea that he was doing this. And he's like, your hearts are more horizontal. You need to respect anatomical planes for a reason. And maybe, we haven't done that. We haven't communicated. These are the struggles you're leaving us behind. Because this is 8th grade to me. I mean, for the patient, it's also, but it's also to me and the staff. And this is the, pre-Rampart or egg nest days or whatever. This is a lot of radiation. Yes.
But it goes 2 ways, too. I mean, there are surgeons that use graft markers, and there are surgeons that don't. I mean, I don't get that either. Like, why don't they just universally use them?
It's funny, actually, you mentioned that I just had a conversation with all of the surgeons at our center about their markers as well, and I think that's the whole point. You just need to communicate with them, because I sent an email. I said, listen, can you consider some graft markers? It saves contrast, radiation, frustration, and they said, sure. So, just a conversation.
So when you decide to stop fast intervention, can you talk about your thought process about ballooning a septal, what balloon you use, how high you go, and all that?
Yeah, so that's a good one, because sometimes in these tough cases, I have rotobladed the LAD, but I don't want to relieve the LAD of its stenosis, because I want the lima to keep flowing. So just very gentle balloon angioplasty, and for the septal, I think I usually take a 2.0 compliant balloon based on the quality of the septal. This was a good quality septal collateral, so I was very comfortable using a 2.0 balloon, and I am ballooning where the LAD into the septum and also septum into the right corner, into the PDA, so that the flow is maintained. And you don't need to go for broke. You don't need 12 atmospheres or something like that. Gentle 8 to 10. It's just massaging, keeping, not causing dissections, because if you cause dissections, you'll cause injury and closure, etc. You're just suggesting and allowing it to stay open.
You know, with that work you did, opening the LAD, you got good access to septals. Did you consider maybe using a DCB or maybe stenting, even stenting proximal, to make sure that when you would come back, you would have access to mid? Were you worried about the impact it would have on the lima? Because I think an old lima just is so robust.
It is, but I am still, respectful of it. And what if, I open the LAD, then I'm adding more time. So remember, by the time the perforation has happened, don't want to increase my time because I want to get my gear out and give protamine. So that was another reason to just balloon the septal collateral and go. If I did not have the perforation, even then I'm like, that's why I bring these patients back in 6 weeks compared to my star patients where 8 to 10 weeks is a better option. So I usually don't tend to balloon. I had a similar case, stent. I had a similar case where I had to fix the native, open up the native LAD to get access. I pretty much did the same, rotobladed it, ballooned it. And rotoblation, that's the beauty of it. You have cleared a bunch of calcium out there. It stays open, unlike just plain old balloon angioplasty.
Great.
Right.
Thank you, Arasi. Thank you.
Okay, well, welcome our next speaker, Dr. Sandeep Jalli on CTO case number 4.
No disclosures. So this is a 68-year-old male with a history of cabbage, lima to the LAD, vein to the OM, and a vein to the PDA, heart failure, hypertension, and hyperlipidemia. He was having pretty significant angina despite being on meds, taking sublingual nitro 3 to 4 times a week. When I met him, he actually told me just walking down the Minneapolis airport, he had to stop basically at every gate because he was having so much chest pain. So he had angiography in 2024 showing occlusion of both vein grafts and RCA and left main CTOs, and he was referred to us for CTO PCI. We did an MRI before doing this. He had an EF of 30%, non-viable mid to distal LAD territory, and all the other segments were viable. So essentially this gentleman has a lima to a dead LAD and 2 CTOs. So these are the initial dual angios. We have a guide in the lima and a guide in the right. You can see there's a blunt proximal cap of the RCA CTO, and there's collaterals from the LAD that pretty much fill everything. We also tried to get a guide in the left main. There is essentially no left main. And then again, you can see that the lima gives collaterals both to the circumflex and to the right. I'll just let everyone ponder what CTO they would open. We chose to start with the right. Again, it has a blunt cap. The length was probably around 100 millimeters. We knew it was really calcified by CT. We had septals from the LAD, but that would require going down the lima, which we weren't really considering. And then we knew from CT that there was an occluded vein graft that had a bit of a stump, so that was the second option. So our initial plan was to go retrograde via the occluded vein graft, and then perhaps try to go antegrade if that didn't work. I'll just pause here and let everyone consider whether they would do this case with or without mechanical support. And then as you think about that, consider that this patient was actually paying cash for this procedure. So we decided to do a right heart cath, which looked fine. So we proceeded without support. The other wrinkle in this was that he turned out to have pretty significant PAD. That is my hand, sorry, but you can see that I have no fractures. Took a little bit of doing, but we got femoral access on both sides. Started retrograde through the vein graft with a multi-purpose and a Pilot 200. Pilot 200 went for a bit and then kind of stalled out, so we switched for a Mongo, which goes a little bit further and then also stalls out. So at this point, we did something a little bit unorthodox and did a contrast injection through the microcatheter. You can see there's some distal filling down there in the first angio. And after that, the Mongo actually advanced pretty easily. At this point, we're feeling good about ourselves. The case is proceeding smoothly. We tried integrate with multiple wires. Everything just went into a side branch. So we did base to solve that. And we had a Mongo that kept going into a marginal. So we did side base to get out of this marginal. And everything seems to be going sort of as planned at this point. I'm happy with my life, okay with not eating breakfast that morning. After this, things get a little bit hairy. He has some SVT, some sinus bradycardia, eventually has a PEA arrest. So we called for anesthesia. The patient was intubated. And this is the first time I've not been able to push an Impella CP in. So it took a lot more pushing to get in. At this point, we paused for a little bit. He stabilized, he was intubated. We spoke with our heart failure colleagues about what to do. And we sort of thought that he was on mechanical support at this point and was stable. And we thought we were quote unquote close, so we should continue. Despite being on the Impella, as we started to continue, he deteriorated again. So at this point, we cannulated for VA ECMO. We were having these issues with ECMO flows being low, and we couldn't really figure out why. The venous cannula and arterial cannula both seemed to be in good position, but again, there was that left iliac lesion that I showed you earlier, and we thought maybe that was the culprit. So we ballooned this, and that seemed to help. So we continued on. At this point, we'd lost both of our femoral accesses, one for the Impella and one for the arterial cannula of the ECMO. So we had left radial and then single access through the Impella sheath, and basically started all over. Fortunately, the wire went sort of smoothly into that extra plaque space. You can see in the second frame, it actually seems to go down into the graft anastomosis. So we have a target now for our retrograde wire. So again, we used this antegrade equipment as a target. We were able to advance a retrograde wire into the native RCA. Did reverse cart, externalized an R350. And then had a lot of difficulty wiring the PDA through this anastomosis. Used a dual lumen, couldn't really get anything. Did actually kissing with retrograde and antegrade balloons, and were able to successfully wire the PL. Ballooned everything. And at this point, we noticed that we have some suspicious staining, and we definitely have a distal wire perf. We went back and forth for a long time about what to do with this. It looks like it's probably in the septum. On the other hand, this is a patient that's had bypass. He's also on VA ECMO. Do we really want to leave this alone and come back and worry about it later? So we decided to coil this and put Concerta coils in it. We stented the PDA, did nothing fancy, just T-stented, and then put stents in the native RCA and the PL. And throughout this entire thing, the ECMO flows were sort of up and down. We weren't really sure what was going on, but the patient was doing actually relatively well. We put distal perfusion cannulas in, and then took a little check and noted that the arterial cannula of the ECMO was basically almost out and hanging on by a thread, so replaced that over a wire. He was actually transferred to the ICU, and this is a CT scan they got in the ICU after we were done with the case. It's sort of hard to interpret because of all the gear in the aorta, but there's basically this giant intramural hematoma that sort of takes up most of the ascending aorta, and there's a lot of calcium there too. So the next day he was doing well, and we decided to remove all the mechanical support, given that it probably wasn't the greatest thing for this aorta. Unfortunately, despite the mechanical support being out, he did well for a couple of days and then developed some arrhythmia issues, ended up getting an atrial pacing lead, and then sort of decompensated and passed away. So the learning points for me for this case are that CTO PCI in patients with significant ischemia and heart failure always carries a risk of hemodynamic compromise. We had to change strategies and start over multiple times. And that MCS in patients with PAD can require vascular intervention. I think the really sort of big thing to think about is the juice worth the squeeze here? Was this all worth it? Thank you.
Well, thanks for sharing this case. There's a lot of things to learn. And while I was following your thought process and how you were proceeding on the initial procedure, I was a bit surprised of how. So, what's the likely explanation of the hemodynamic compromise? Because it sort of comes as it came as a surprise, right?
Exactly. Yeah, it came as a surprise to us too. I think if you look back and really pay close attention to those initial dual angios, there's this very small sort of epicardial collateral from the proximal RCA that does fill a little bit of the left main. And I wonder if that was enough to do it. I don't really have a great answer, to be honest with you.
And what about the lima? Were you able to reshoot the lima, or were you?
We did reshoot the lima. There were no problems with the lima. We actually even did a TE because we were concerned we might have perforated something and not noticed it, and couldn't really find an alternative cause.
I wonder if when you place an injection through the microcatheter, through the vein graft, whether some of the schmutz in the vein graft went distally and cast, some sort of acute lesion in this chronic process or something like that.
Certainly possible.
Yeah, it's a good thought. Although it could be, it's something that I've been doing almost routinely when using vein grafts to get, because it's amazing how it can change your way of doing it, and never, but here it definitely, when you inject it, you could see the vessel. So that's maybe, but it just brings the fact that sometimes we have these, I don't know if anybody can share situation, you have mysterious sort of behavior of the heart.
Yeah, I would
you
just share.
don't get the point in, but you're like, you knew that there was a higher risk. You don't know exactly what happened, but you were just working in those coronaries, and the reason why they collapse is not always very clear.
I'll just share a couple of, I have had several proximal RCA CTOs where there's just maybe 10 millimeters or less of stump that you deeply intubate, and for whatever reason this induces some sort of a vagal reaction and they PEA arrest. And I've actually done a stingray reentry with CPR because of this. I mean, it's just, I've seen this, and I don't know that I can explain it, but I've seen this.
So some kind of humoral sort of reaction to what we're doing in the heart, because we know, when you in cardiac tamponade or pericardial, they sometimes have, and one thing I also noticed, that bladder was pretty full, and I've seen people coding on the full bladder. I've seen really freaky hemodynamic compromise on a full bladder. So don't treat it with neglect. If you see a full bladder, treat it very seriously. Huh?
Yours are the patients.
Yeah, mine I can tolerate usually, but the diapers is very good too. But I'm just saying this is no joke, and Olga can actually testify this. We really had a patient who coded on a full bladder, and so that's something important. I don't think it was the reason why here, but honestly, these are things we have to think about.
So one thing that we've had that we keep an eye on because we've had experience with or issues with is for RCA CTOs when you go with an AL and then eventually while you progress with the case, sometimes the AL drops into the LV, or not into the LV, but kind of sits on the aortic valve and causes AI that you won't notice until the patient is decompensated. We've had cases where they really decompensate quickly. We don't know why. You just pull the guide and they do fine. So that's one thing to keep an eye on. What's interesting about this case, and I applaud you for this, it's a 10 hours case. It's 600 minutes, 200 of contrast. So that tells you a lot of how imaging was used and kind of understanding the anatomy to try to figure out where to go and what not to do, or where not to go. It's very difficult to do, but I applaud you for 10 hours case. I mean, it's not easy. I can't imagine how you felt at the end of the day.
Yeah, I think absolutely, this is a case that was puzzling in terms of that hemodynamic collapse, but I think it, emphasizes the importance of having a clear algorithm to sudden hemodynamic collapse in a case and running through that, and when you're not getting answers, thinking outside the box. But sometimes, unfortunately, these complex patients just have such little reserve. It could be any small shift in the situation that tips the balance. So thank you for your case.
Another important point was, like, you use almost 137 minutes of fluoro with 1.4 gray of radiation. So you can actually, do these cases, keeping an eye on low fluoro rates and keeping an eye on your radiation exposure. So that was remarkable.
I guess the question I have for you guys is, would anyone have said no to this gentleman?
Well, he had symptoms, right? I mean, this is something where I think your risk-benefit analysis was completely appropriate. I don't think anybody would argue that.
Yeah, I think if you're, it depends on your setting, right? If you're working with monos, I mean, yes, you'll say no, you'll try. You can get things done safely. But if you're in a new job where you don't have a lot of support, you're trying to prove yourself as a CTO operator, I would either consider sending it to someone or getting someone to help you with it. When I started my CTO practice, I always run it by the surgeons first to have support and kind of like, should I go with this? And if they say no, I kind of pause and send it to someone else. But I think the most important thing is understanding your surroundings and what you can and can't do in that setting.
I think the other question at least I ask myself on a regular basis in these patients with cardiomyopathies is, when do you use a support device up front? Now, I think in this particular case, with the way you're going about doing it, I agree with you. I probably wouldn't do it up front, but I think hindsight's 20/20. It's like, you have no idea why this happened. Would it have made a difference if you put a support device in up front?
Yeah. In such situations, I think that the CTO that scares me the most is going down the Lima retrogradely to anything else. And in those cases, we've done only one case without MCS and gravely regretted it. So I think as a rule of thumb, if you had to go down the Lima through a septal, or what the previous case was, I would go up front with MCS, even if you don't think you're going to need it, or you'll be as quick as you can, you'll regret it.
Also, it depends on the amount of the donor vessel amount, the amount of myocardial that's supported by the donor vessel. Every time we inject through it, we're causing ischemia and repetitive ischemia, right? If it's one IMA providing collaterals to the circuit all the time, so it's amazing how the longer we work in the heart and whatever we're doing, injection, whatever, we make these heart usually sicker than better. And that's something that I've learned over the last 15 years, is that it's not the branches you open initially that makes this heart better. Everything you've been doing is make them sicker, and you want to make it go through, and so that the longer term they'll get better. But you make them sicker initially, for sure.
I know you guys talked about, obviously, whether to stop or keep going after the first cardiac arrest, but I'm interested, anybody in the panel would have stopped or kept going after the first cardiac arrest and had a CP?
It's a good point. At this point, usually if you have, if you're on ECMO and you've stabilized the situation, it might be reasonable to stop if you don't exactly understand what happened, right? I don't know, it's sort of my sense, but it's debatable, honestly.
Yeah, I'm as guilty as anybody, but we probably underestimate the total ischemia time when we do the procedures. I know the proximal RCI is just like small branches, but we don't know how much the patient was relying on those small branches. And the second comment I wanted to make is when you had a problem with left internal iliac and had a arterial cannula. So one caution is when you balloon and you create a retrograde dissection, because of the high flow, it can propagate. Mm-hmm. So if you are unsure, either probably just better to stent or put a long dry seal up into the aorta and put a ECMO cannula through it. So we have had a couple of cases like that. So we try not to balloon on the arterial side of the ECMO cannula.
It's a good point. Quickly, because
Yeah,
we're
just-
running late.
Yeah, very quickly. I mean, the lima being, giving the whole myocardium and the guide in it the whole time, even though you were not working through it, could it have been the cause of global ischemia? And could you potentially, because you're not working through it, put a side-hole catheter, even though you don't like it, just to increase the blood flow there?
So our practice was if we were not injecting the lima, or the guide was not engaged. So there was just a wire and no guide.
Thank you so much for sharing this. Then we have Salman Allana for the chronic total occlusion case 5. Nice title.
Good afternoon, everyone. So the last case of this session, sorry, I forgot my. These are my disclosures. This is a 66-year-old man with hypertension, hyperlipidemia, who presents with medically refractory angina, normal left ventricular systolic function, the stress test showed anterior wall ischemia. And coronary artery angiogram was done at the Arasi hospital and revealed chronic total occlusion of the mid-LAD, mild to moderate non-obstructive disease otherwise. He had unsuccessful antegrade attempt of the RCA, LAD CTO at the RCA hospital. That was unsuccessful, so he was referred for CTO PCI of the LAD. So this is normally, since this was a case that was a prior failure, although all the antegrade at the RCA hospital, I usually go bifemoral. I use an 8 French EBU guide, EBU 375 into the LAD, engage the left main, and AL 1 guide, 7 French into the left femoral artery. Dual coronary angiogram was obtained, and you can see that there is no significant disease involving the right coronary artery. You can see that there are epicardial collaterals from the right coronary artery, very, very tortuous, that are coming into the LAD. There may be some septal collaterals, hard to see. The LAD CTO is very, very ambiguous. It is probably between this septal that's coming off and the diagonal artery. So it's probably around there, but it's the proximal cap is extremely ambiguous. So ambiguous proximal cap, length is about 20 millimeters. Good quality distal vessel, although underfilled. And the collaterals, possibly septal collaterals from the RPDA and the epicardial collaterals. So the plan was antegrade wiring using IVUS guidance as the first strategy as per the global CTO crossing algorithm if possible. Second option, retrograde via the septal collaterals, and possibly ADR versus retrograde via epicardial collateral as the third option. So advanced a wire into the into the diagonal artery and manual pullback from the IVUS, and really could not see the proximal cap very well. And that's one of the limitations I've experienced with IVUS guided puncture, is that when there is significant calcification, it's hard to locate the proximal cap of the occluded vessel. So decided to go retrograde, did multiple retrograde attempts via septal surfing and also contrast guided injections with the SU-03 and Cihan black. However, these retrograde attempts were really unsuccessful, could not cross the septals. So went back with the IVUS, went back antegrade, went back with the IVUS, and I thought that I may have seen the proximal cap and wired it. However, you can see that the wire is outside the architecture. This was a polymer jacketed wire outside the architecture, and therefore was withdrawn. So at this time, I decided to do side base with the wire in the diagonal artery. IVUS the diagonal artery. It was about 2.5 millimeter vessel, a 2.5 balloon from the diagonal artery into the LAD, and did a side base along with a Mongo and Caravel microcatheter. However, this was unsuccessful, as the knuckle kept going either into the diagonal artery or it really would not advance. So at this time, I am really, it's a difficult situation, everything is failing. Another option here would be to do a base, where I would use the same diagonal wire, but shift my dissection cap more proximal. However, I risk losing that large septal vessel. So that was not very appealing. So I'm contemplating whether to do base or take that epicardial. However, then subsequently decided to what we call the double side base technique, in which I have a 2.5 millimeter balloon from the diagonal artery into the LAD, and a 2 millimeter balloon from the LAD into the diagonal artery. And there's a microcatheter, and it doesn't project very well, which is, of course, Turnpike LP. And using that, so these balloons, of course, not only blocked the wire entry into the septal and the diagonal artery, but also allow me to create the dissection plane protecting these wires. And with that, I was able to knuckle a Mongo into the extra plaque space. And this is how it looks like. This is what we did. A 2.5 balloon from the LAD into the diagonal artery, and a 2 millimeter balloon from the LAD into the septal, along with a microcatheter pinned between the balloons. Of course, this is a 3-dimensional structure, so you have to assume that the microcatheter is pinned against the wall, and that allowed the Mongo to go into the extra plaque space. So after that, did the retrograde angiogram to confirm that I am in the architecture of the vessel with my Mongo, and subsequently advanced a Stingray LP balloon, did a double-blind stick and drive using a Gaia X3, and you can see on a retrograde injection, the wire enters into the distal LAD. Subsequently, did balloon angioplasty of the LAD and the diagonal arteries, follows by IVUS-guided DK crush stenting involving the LAD and the diagonal artery with a nice final result. So it's not playing, but would you be able to play that? I'm not sure if it's not playing. So. So diagonal has good flow, LAD has good flow, and the septal also has good flow. So we got a good angiographic, and IVUS confirmed good stent expansion and apposition throughout. So overall, we describe a double side base technique, a modification of the base technique as a mover cap technique with CTOs with ambiguous proximal cap, which have 2 side branches. It can be utilized when proximal cap is ambiguous between the 2 branches, as mentioned, and can facilitate antegrade and retrograde dissection reentry. And continued problem solving and thinking outside the box is key for achieving success in CTO PCI. Thank you. Happy to answer any questions.
Salman, have you had any luck with IVL for these stumpless proximal caps that are calcified where the IVUS is useless? I've seen some reports of that. I've had limited success with it myself. Curious if you've had any luck with it yourself.
Yes, for sure. Have done shockwave guided base, and that actually does help. So probably would have been a good option in this case too. The only issue in this case was that I had to risk losing the septal, but definitely IVL guided, or you could have used an IVL balloon from the LAD into the diagonal artery, and that would have allowed me to get into that. I did not think of it, but I have used IVL with good success.
Hey, Salman, can you explain a little more details? Well, I know you had 8 French guide, right? What platform balloons you are using, what microcatheter, and can you do it with 7 French, or what balloons? What are some of the nitty-gritty details we should be aware of?
Yeah, so I was lucky that I had an 8 French guide here, but I don't think it would have gone 2 balloons with a Turnpike LP microcatheter. Probably wouldn't have gone with the 7 French system. So it was, and that's many times, especially prior failures, I tend to go with an 8 French guide because I know I'm gonna even if they are not done by CT operators, I know that they have tried antegrade wiring. I'm gonna have difficulty. I would just go with an 8 French guide in those situations. But yeah, I think 2 balloons, 2 or 3 wires, 1 microcatheter, you need an 8 French guide for it.
And you were using semi-compliant balloons or NCD?
Yes, semi-compliant balloons.
So sometimes in situations like that, when you actually try to use IVUS guided cap, proximal cap ambiguity to resolve it, if you can't see it in the DIAC, sometimes IVUSing down the septal, if the LAD comes off a different angle than what you expect. The comment that, not the comment, but I wanted to ask the panel, we doing 300 CTOs a year, and we're 99% bifemoral 8 French. We've had cases where we had to go radial. I'm 38, and I'm already having back pain from doing long procedures. How do you deal with left radial access? Is it worth the toll on your body? Is it worth, like, if you fail the CTO and you're like, yeah, well, I wish I went femoral and I had more support and more control over the procedure. And then when you're busy schedules, you don't have the luxury of seeing the patient for 3 months again in the cath lab. So how are you going around your plan? Do you go planning for success, like go big or go home, or are you trying to do what's best for the patient?
That's a very good question. So I typically do most of my cases radial femoral if I can do it. I usually don't do a lot of bifemoral unless I have access issues. I personally almost never use left radial. Sometimes I'll do it if it's a low JCTO score and I think I'm going to be successful pretty quickly. Otherwise, I'm usually doing radial and a femoral access.
You know, you're asking the question and I came, you know, when we started doing CTOs, I was in the church of radial access, and my peer pressure would have been if ephemeral complications. I started doing everything bilateral radial. I can tell you one thing is that over 15 years, I might have used, I think I've never used an 8 French retrograde, never. I've used probably 85 to 90% 6 French. And because most of your devices are torquing devices, you don't necessarily need that push. You can use guide extension and stuff. So 6 French usually is enough retrograde. Antegrade, I went through the whole 6 French, 7 French, 8 French, because Stingray was only 8 French compatible, back to 7 French. The whole thing is that I think with a 6 retrograde, a 7 antegrade, you can do pretty much everything nowadays. And now I moved from bilateral radial to single femoral. So I do everything one femoral, 6 and 7 on ipsilateral side, and I do everything like this. So the patient loves it. I love it. I don't have any back pain anymore. I'm just saying that I will publish my data because I must have done 200 cases and they're well tolerated. But you're raising a very good question about the left radial because I really hurt my back because I really needed to do everything radial. They were like, I was this crazy guy in Quebec City doing all these bilateral radials. And yes, at some point it was like, cool, I did that. But, you know, getting older, like my back would feel it. And nowadays, a left radial, I just try to avoid it. And I would say the best prevention is we have to take care of ourselves. And I don't think it's worth it nowadays. You doing like, you know, dogmatically bilateral radial because you're supposed to save complications. The reason, the data is not there. The data does not support lower complication from transradial approach. So we have to move on and be reasonable with what we're doing.
Totally agree with everything you said. I had switched to doing conventional right radial 7 with 6 French snuff box and, you know, lay the patient's hand on their abdomen. And for me, that ergonomically worked until we switched to Rampart. And once we switched to Rampart, the priority became every case must be done with environmental radiation protection. We'll use 1 femoral with ultrasound guidance and 1 radial. And that's sort of been our default at this point.
I have to say, similar to what Stephane said, I definitely mix my access up from time to time, don't get me wrong, but over time, I've developed more of a tendency to avoid left radial for ergonomic reasons for myself. So especially if it's an extremely large patient that I'm reaching over throughout the case, I find it hard on my back as well. So there are times when I've made that decision just for my own durability throughout the case, to be honest. If I have to use a left radial, I now have a Cobra board, which is kind of nice. So I place the arm right across the body and make it as accessible as I can. And there's other things like extending taking a longer sheath, extending it out of the radial, which I know you've done a lot of. there's ways to make it better, but if I have an equivalent choice for myself and I think it's going to be hard on me in a large patient, I'll avoid it.
In the old days when I made that decision, bilateral radial, femoral was a big needle, a J-wire, and an RP bleed every 20 cases. It's nowadays, now it's ultrasound, micropuncture. It's much safer. We're in a different era. And I think it's important to recognize that femoral approach has become safer. And I think it's been the growing pressure of development industry, microcatheters, everything. But you go in Europe, they don't use micropuncture at all. They're all sticking with the big needle and a J-wire. They don't know about it. Yeah. And when you go there, that's the reason why they're still stuck in bilateral radial. But that's something that has struck me over the last 3 years. Everywhere I've gone, doing cases there's no micropuncture. You won't be able to find it any.
No ultrasound, cook needle.
They do ultrasound, but they do ultrasound with the big needle, which is, you're missing a bit of the overall concept of minimally invasive in some way, I would say. But
well, we'll get some more information from the rebirth. I think Dr. Ravakis is the primary investigator on it, comparing radial to femoral with micropuncture or with cook needle. Randomized trial. So
I think it's very good. Well, I think it's time to close the session. Thank you very much for your attention. Hope it was instructive, and see you later.